by Ibrahim El Adl on pelvic trauma classification technique and embolic treatment. Is he here? Yes, please.
Good afternoon, everyone. I want to thank Chairperson here. I want to thank Scientific Committee, Professor Ahmed Kamel. My talk today about interventional radiology in pelvic trauma. I have no conflict for interest. Pelvic trauma is a broad term consisting of injuries which may be incurred due to iatrogenic injury, low and high velocity penetrating trauma, and blunt injury. So it accepted that pelvic trauma is causes a high degree of morbidity and mortality due to vascular injury. A lot of etiology here can occur due to motorcycle crashes in Egypt. Also automobile crashes and gunshot wounds also contribute significantly. Endovascular intervention can be a life-saving in patients with hemorrhage from pelvic fractures. In most studies, angioembolization or peritoneal pelvic backing with external fixation may be demonstrated due to decreased mortality in patients with pelvic fractures. Diagnosis of pelvic trauma related to hemorrhage can be done clinically and by imaging or during operative repair of pelvic fractures. Presence of unstable pelvic fracture is a predictor of arterial extravasation. Here in this diagram showing pelvic fractures, it's the most common size of pelvic fracture with arterial extravasation in the form of sacroiliac and pelvic regions. Radiologists have a crucial role in between the diagnosis and treatment. First, to establish the location of the active bleeding, also to control bleeding effectively in critically injured patients in a timely manner. Imaging diagnosis must be obtained by CT, contrast-enhanced CT scan, especially in stable patients or patients who are responsive to resuscitation. It's fast and available in most centers and provide detailed information about the type and the location of hemorrhage, also the presence of vascular injury. Here in this diagram showing CT contrast-enhanced CT showing contrast extravasation in the left side of human pelvis, also another site of abdominal injury or lung contusion and thoracic trauma. Here also the contrast extravasation due to vascular injury. In the event if patient is hemodynamically unstable, a fast scan used to diagnose intraperitoneal bleeding in patient not responding to fluid resuscitation. If intraperitoneal and intracystic bleeding are excluded and the patient is still hemodynamically unstable, a retroperitoneal bleeding is suspected. Actually, there are multiple classifications of pelvic fractures. One of the most two important classifications of pelvic fracture is the Youngberg's classification, including anteroposterior compressions, subtypes 1, 2, and 3, lateral and vertical shear. Initial management of patients found to have evidence of unstable pelvic fracture. It depends upon the degree of hemodynamic instability. Early management including identify fractures, active hemorrhage, and intra-abdominal injury. An institutional algorithm for triage of patients with pelvic fracture. Here are the most two important positions or the important conditions. First is unstable hemodynamic patient. We do fast scan here and undergo angioembolization. Also, if the patient is hemodynamically stable but he have unstable pelvic fractures, with CT angiogram showing contrast blush, he have to go under angioembolization as well. Here we talk about embolization. It's an non-surgical, minimal invasive procedure to control hemorrhage. It demonstrates successful selective embolization with control of hemorrhage as demonstrated by lack of contrast after embolization. Actual time is very, very important factor here in embolization. If embolization is indicated, the choice of embolizing agent and exact embolization depend on angiographic data, anatomy, and hemodynamic stability. Embolic material is chosen according to bleeding site and the presence or absence of coagulation abnormality. In hemodynamic and stable patient, we can go to multiple bilateral bleeding. Non-selective bilateral embolization of the internal iliac arteries should be performed, and we have to go with the risk of gluteal claudication and pelvic necrosis if the non-selective embolization done. Here is the most common embolic agents used according to size and site of bleeding. Actually, the most important embolic agent we used is the coils in the aid of onyx or histoacryl. or glue in general. Microcoils most widely used. In addition to thrombogenic coating, most coils have small fibers attached to the metal component, and you have to choose the diameter at least 20 to 30% superior to the vessels to prevent migration and non-desired embolization. And here's a picture of my coils. Another case of we used coil for embolization here, and after good embolization. Another case of it's done from literature. Another case of left-sided pelvic fracture. Here we use coils and in the aid of gel foam. Another case also showing extravasation of contrast here in the left side of internal iliac artery, and after super selective embolization by coils, here is lack of contrast after embolization. Also another case of microcoils embolization. Here we can see there are multiple sites of contrast extravasation, and we use coils here to stop the vascularity. Gel foam used also if we have multiple contrast extravasations or multiple bleeding sites, and we can't do coils. Here we do gel foam to stop the bleeding as much as we can. Actually, multiple studies done showing talk about pelvic angioembolization and trauma. Here in this study done in internal geography surgery, she said that pelvic artery embolization is very effective in management of hemorrhage. Another study done by Dr. Ahmed Kamil, 2021, said she compares the various embolization techniques and the potential complications. Other multiple studies done also. Here we talk about factors affecting outcome of embolization. Time is a very important predictor for the outcome. Some studies said that it must be not exceed to 60 minutes, but in some studies in Europe and North America, they say it may last for 3 to 4 hours. In hemodynamically unstable patient, time restriction and hemostasis is very important. Application of pelvic binder, presence of highly trained emergency and anesthetic physician, and activation of blood transfusion is important. It's recommended to perform selective or super selective embolization of more distal vessels to decrease non-targeted embolization and to decrease risk of surgical site infection. Typical coils are imbricated with thrombogenic materials which activates the coagulation cascade. We can use multiple coils as well. Here we talk about complications. Complications may be related to the arterial access point, typically in the femoral artery or the procedure itself. Access site complications including bleeding and hematoma, pseudoaneurysm and AV fistula. So we have to careful consideration of necessary embolizing target and patient anatomy to help to minimize complications. Also an important point, the majority of complications related to arterial embolization is due to non-target embolization, or an unavoidable result may be done due to a pelvic necrosis or ischemia. So we have to balance between hemostasis and complication risk. At last, recommendations: pelvic trauma has a potentially life-threatening catastrophic outcome due to wide variety of vascular injury. Many management options are available with endovascular management, ever growing in influx. Initial management should focus on patient stabilization using a multidisciplinary approach, followed by cross-sectional imaging. Endovascular intervention can provide a rapid access and control of hemorrhage, leading to better outcome. At last, we have IR network coverage for 24/7 access. Thank you.
Thank you very much, Dr. El Adl.
Thank you.
And we continue with Dr. Ziga Sizman. Ziga Sizman from